Good afternoon, everyone. So thank you for being here. This is the almost 6th hour. So I'm the last presenter. I work at a university in Florida, South Florida, north of Miami, called Florida Atlantic University. We have a research center for tinnitus and hyperacusis, and this work partially was in the collaboration with one of my colleagues, Dr. Connie Porcar. And what we are going to do is we're going to have a little bit of introduction and some studies and our current research. But the goal of my presentation today is to see what we can do as academicians at the university for those people who have misophonic problems. And I'm going to give you examples and cases of patients who have had this condition and they had to leave school because there was no services for them. So I'm not going to go into the definition of misophonia and hyperacusis. We are very familiar with this. Basically, how I describe it to the patients is that misophonia has nothing to do with the intensity of the sound. It's just the content of the sound and repeatability of the sound and the pattern of it. On the other hand, hyperacusis is more related to the loudness perception. So a person with misophonia, you can go to a club with a loud sound, nothing happens to them, but the person next to them, if they're chewing, they will be annoyed by it. So it's a selective sound sensitivity disorder, and what we have is it generates some emotional reaction to it, and we are not sure that if it's a hereditary condition, although I have seen many cases that they have reported they have a similar case in their family, such as their father or their sister or mother had similar condition. So there may be a gene for it. Actually, one of my patients sent me a report that she has had a mutation on chromosome number 7. So we are going to see these type of reports from people. So there may be some hereditary aspect to misophonia also, although some people may refer to it as a cultural, deviation or variation, if you will. So there's a nice movie has been actually made by a group of interested individuals it's a documentary about misophonia. It's called Quiet Please. And my university was involved in it. One of my colleagues who was a student of mine, Michael Menino, Dr. Menino, who just finished his PhD in neuroscience, and he is in this movie, and I highly recommend that you watch this. It's a very informative movie that you can share with your patients to know what is going on with misophonia and what kind of origins of suffering people have. So one of the problems with misophonia is that they have reported that they have inability to refocus their attention on the cues when a trigger stimulus is present. So just imagine you have a student in the classroom, you're trying to teach them, and there's another person is chewing or open the bag of chips and starts clicking their pen or typing on a typewriter or a computer, and all of a sudden they lose their attention. What happens when they lose their attention? Of course, they're going to miss the important data that are being shared in the classroom. So it can be an obstacle for learning. So that's why that we designed this type of study and approach. So the impact of learning in academic settings is important for us. It was important for us. And as I told you, students have left colleges and universities because they had misophonia. So we need to come up with a solution for them to help them. Unfortunately, misophonia and research for it is very, very limited. I mean, if you go to PubMed.gov and type tinnitus, you will see like 20,000 articles. For misophonia, the last one that I checked was less than 60 articles, 60 research. So we need to have a lot of research done in this field. A study that Dr. Irfanian and her colleagues performed, they studied 300 people, and they noticed that most of the times actually misophonia has an origin in childhood. I have seen children as young as 5 or 6 years old with misophonia. The first misophonic patient that I saw, it had no name for me. Like 22 years ago, a pediatrician referred the patient to me, and that this child cannot go to the restaurants because she cannot tolerate the sound of the fork and knives. So I had no idea. So what I did, I couldn't call it a hyperacusis. I didn't know what misophonia is because there was no term before Jastrow came up with this name, or before Dr. Johnson came up with the triple S concept of sound sensitivity, 4S concept. So on that time, we did a lot of counseling, and child got a little bit better. We made sounds for them to listen to those sounds, to reduce their reaction to the sound, and we did some desensitization. But this group studied, and they, as Dr. Irfanian mentioned a minute ago, that they noticed that PTSD and ASMR report in those with misophonia. So there's a lot of emotional interaction in misophonia. There's a lot of limbic system involvement. There's a lot of amygdala, the fear, cingulate gyrus, all of those parahippocampal gyrus, all of those areas that are related or considered limbic areas are associated with these type of perception, negative reaction that the patients are referring to. So there are some similarities that Dr. Fernando mentioned. There are some similarities between tinnitus and misophonia. There are areas in the brain, if you do fMRI, you'll see that areas in the brain that can be activated in tinnitus patients. And some of these areas, including the anterior insula, is also activated in studies that specifically looked at misophonic patients. So this study, the brain basis for misophonia by Dr. Kumar, was done in this town in London, and it showed that when they did fMRIs, they showed activities in the anterior insular lobe. And anterior insular lobe, the insula is a part of the limbic system. There are a lot of kind of multimodality inputs to this area, and they have seen activities in this region of the brain in the population who suffers from misophonia. So, what triggered our study? Why was I interested in this? So I saw a patient that was referred by Dr. Jennifer Brout to me as a special case. He was a 24-year-old male, reports inability to handle any noise, feels all the noises are magnified and debilitating. The sounds such as birds, chirping, clocks, any sound in the world that you can think of, it was annoying to him. He had a condition called I discovered that he had a condition called perineurosis. This is a condition that you hear sound and it stays in your ear for a while. It continues echoing in your ear and your brain, and that's a temporal lobe involvement. That's a neurological condition. He had OCD and he left school because of this condition. Second patient was a mother of two, had a head trauma, developed sensitivity to sound after the trauma, triggered her misophonic symptoms are triggered by noises in the classroom, chewing sounds of the spouse, and she left school again because of her misophonic problem. So she also brought these pictures to me. It seems that Churchill, these are pictures from the British Museum right here. She took these pictures and brought to me. She thinks that Prime Minister Churchill had some sort of sound sensitivity. Why? Because there are specific orders from Commander-in-Chief that no whistling in here. And the typewriters were actually imported from the United States during the war, World War II, that were noiseless typewriters. So there were absolutely supposed to be a quiet area for the area that Prime Minister was working. So who knows, maybe he had some sort of misophonia or hyperacusis. So our research, we looked at the awareness and responsiveness among academics for misophonia. I'm in the state of Florida. The state of Florida has many universities, but 10 state universities. And these 10 state universities, 6 of them were able to contribute to our research. They responded back to us. We sent around 9,000 participants. Around 14% of the participants came back to us. So we had a relatively good response rate. So we surveyed the faculty to see if they know about misophonia. If they know about misophonia, what would they do for them? So we had the IRB approval, we sent it to these universities, we sent a consent form online, and there was a yes and no response method that said, do you know about misophonia, yes or no? And then whether they knew it or no, they were kind of directed toward the completion of the study. So 686 faculty members who taught undergraduate courses communicated with us, and some of the data are here, but very briefly that I can show you that it showed that 18.4% of the participants, maybe like around 2 out of 10 of the faculty mentioned that yes, I know about misophonia. And so many of them, almost 80%, had not heard about misophonia. And 2.3% of them, of the participants, mentioned that yes, I have had students who came and told me that I have misophonia. What can you do for me? In other studies, there has been another study by another group that they reported 20% of disclosure. But maybe their method was different than us, because these are people who went directly to the professors and instructors and told them that I have this condition. And we recognize that those people, those participants, those faculty members who knew or had a prior knowledge of misophonia, they were more willing to accommodate these students in their classrooms. So the education is a key point for us. Educate, educate, educate. That means that the more you have information provided for them, they will be more accommodating to the students. So those with the information were more willing to consider changing behaviors and allowing accommodations compared to those who reported no knowledge of the condition. So now we know that, okay, there are some interests, there are some people who may want to do more work in the academia to accommodate these students in the classroom while they're learning, while they're taking tests. So as clinicians, what kind of support we need to provide for, or recommendation we need to provide for them? Is this a real disability? So WHO defines disability in 3 levels of the body, person, and society. The body is my impairment. I have misophonia. So it's an impairment. Activities is that my misophonia does not allow me to enjoy certain types of activities, such as eating in a restaurant. And my 3rd level of my disability is my participation. Because of my misophonia, I don't go to groups or leave school. So we can potentially, with this definition of the disability that WHO has provided, any restriction or lack of ability to perform an activity in the manner or within the range considered usual for a human being is considered disability. So yes, we can potentially consider misophonia as a disability because it changes the quality of life. Would you agree? It has changed the quality of life for many of our patients. So it can be disability can be at the level of the body, the person, and the society that diminishes the participation. So at our university, we have tried to bring recognition for for misophonia as a disability. Because we have an office called Student Accessibility Services at every university in the US, and I'm sure that you have it in here too. But because I can see that some of the equipment that you have in here, we don't even have over there, because it's an elevator for wheelchair for those of us who don't know. So there are a lot of respect to the disabled individuals. So our university also, we have tried to communicate with them to provide these type of services, some sort of services that I'm going to mention to our students with disability. So disability can come in it's like a rainbow. It can be many different aspects to disability. And we are hoping that we can put misophonia as some sort of disability, at least at the university level, so they can be accommodated for their work. So, what kind of accommodations? I mean, like I have students when I teach, I have students that, you know, they want me to do a certain, to bring an interpreter, for example, into class. Or I need to wear a special device. Or I can guide them if they want to take a test, there will be note takers, or they will go to a different place or a special room to take their tests. So educating of the academic community is very important for us as clinicians. We need to provide this type of education. In the US, we have a program called IEP, Individualized Educational Plan, that we provide for every student who needs some sort of accommodations. We need to have modification of undesired and unnecessary sounds in the classroom. I mean, like, if a student discloses that I have sensitivity for chewing, I'm gonna not allow students to eat in the class. I'm gonna tell them, okay, I'm gonna give you a short break, you can have your eat, and then come back to the class. So classroom eating habits can be changed, special test-taking rooms can be accommodated for them, and self-advocacy. These, we need to train and educate our students to ask for some sort of advocacy for themselves, to speak up if they have a problem, and ask for some sort of resolution or management or treatment. Thank you.
Congrats for that excellent presentation. Only one question about the second case on the patient.
Yes.
She has only misophonia or also hyperacusis, because she had a previous head trauma.
Yes.
And there are some patients with post-traumatic hyperacusis, for example, when there is a canal superior descent syndrome.
Excellent question. Yes, I started with her. In the second case, this is the mother of two. I started with her as treatment of her hyperacusis. So we have been able to manage her hyperacusis. But as we go in depth, I noticed that that there are many people who have hyperacusis and have misophonia. There are less number of people with misophonia and hyperacusis, but there are more people with hyperacusis and misophonia coexisting together. So the patient has primarily hyperacusis, but no sign of dehiscence or condition related to it. So it's not a vestibular type of hyperacusis. However, she also shows responses, misophonic reactions. In the state of Florida, we have a lot of mango trees. So one of her complaints was that my husband was eating the mango so loud. Because I said because it was juicy, maybe. But the thing is, she has misophonia, but her major problem was hyperacusis. That I saw her for the first time. She was referred by a psychiatrist to me. So we started treatment for her, and her condition, her hyperacusis, has diminished significantly. We are using sound therapy and counseling for her. Her reaction questionnaire has gone down. Her attitude toward life has changed. She goes to the hospital, to the restaurant, and she doesn't start fighting with people while you are making noise when you're eating. So we're seeing a lot of behavioral changes in her.
Any other questions?
Yes. First of all, my apologies for making too much noise. I'm so enthusiastic to be here. I would like to know your thoughts based on, again, your clinical observations. Do you think misophonia is a top-down or bottom-up, let's say, disorder, or both? And how we can actually define this in this very specific context?
Well, that's a very psychology question, but we don't categorize our clients this way. But I can tell you that there are some sort of cause and effect in here. So if it is a genetic condition, so the child is possibly born with it. So that's a different model. So I guess we do the bottom up. If it is a learned condition, that the child has been told that you cannot eat your food with your open mouth, or you cannot, people who are doing this, they are bad people. So that can be a different approach and different level of attention to it. But ultimately, what is important is that they have that condition, and we need to find a way to help them. Did I answer your question?
Yes, of course, and I personally believe even if in people that might be born with misophonia, this process sort of changes through the time.
Mm-hmm.
That's why they become conditioned to that specific sound. They might be, for example, in the very beginning, they are triggered by a specific sound, but later in life, for example, in their late 30s or 40s, it becomes from bottom up to top down type of disorder, or it converts the
Correct.
process.
I always use the example that I learned from Dr. Jaffe that about like our ancestors. Maybe it's wired in our brain that we were so sensitive to little soft sounds that because when our ancestors were hunting, they didn't want to be a prey. So that's why we were sensitive to sounds. Maybe we have that type of ability more enhanced in one person, and other groups may not have that, that type of enhancement of that behavior.
And why this is different from, it makes a difference contextually. If, for example, this sound comes from family members, it would amplify the emotional response. But if it comes from a stranger, it does not, the trigger or the response is not as strong.
I have seen in both. I have seen people who not only from their parents and sister and siblings, I have seen people that they are just annoyed by anyone's chewing. It doesn't matter. Like this person, the second case, she was ready to fight with everyone in the restaurant while they're making noise. No family. But maybe it can be applied to family because, what will they say? The family is going to forgive them. But the person sitting in the restaurant, they may start to fight with them.
Then, from my clinical experience, the patients have expressed that they have more expectation from the family. They should know. And I'm thinking perhaps with the strangers, they always can avoid much easier. So the avoidance like play a role, while with the close friends or the family members is harder to avoid.
There's a question.
Going back to the caveman, I have an interest, and I'm not the researcher, so I'll toss it out to you research people to do this if you think there's anything to it. Some of the ancestry tests, I believe 23andMe genetics test, it comes up with a gene which may or may not be valid, but it also comes up with a profile of where your history comes from. And one of the slices on that pie is Neanderthal.
Mm-hmm.
And I am really curious whether people with misophonia are more likely than the general population to have that slice because they are so reactive in the same way that caveman would have been to sounds that the rest of us pretty easily dismiss. So that's one comment. I have one other thing, but if anybody wants to do that research, go for it.
Well, we have heard about that also for this thing that you are mentioning, it's not just for this population, it has been mentioned to other types of disorders also. It may be a portion of the Neanderthal pie belongs to this group too. But yeah, that would be interesting to look at.
And one other comment I found fascinating in my clinical practice. This person mentioned something and I got curious and I sent out a questionnaire to Facebook groups and sound sensitivity Yahoo group, and so it's not a valid study, it's not randomized, it's not nothing like that, but I just asked people a question about their growing up, what was the religious environment in the family in which you were raised. And what I found, to my surprise, was, except I think it makes sense, is that the families that were more rigidly structured, so they were Catholic or other types of strongly, there's a right and a wrong, there's a correct, it's a top-down kind of organizational thinking about religion and values, had a higher percentage. It was shockingly higher. I looked up the percentage of Catholics and other highly structured religion in the United States was something like 20%, and the number that responded in this little non-scientific survey was close to 60%.
Do you not think that accommodating this problem will actually promote an avoidance behavior and in fact delay people from getting the help that they need to overcome this fear?
Excellent question. If a student is taking a test, they're going to fail that test. They don't care about the treatment. So at that moment, I want someone to help me to have a quiet place so I can concentrate and take my test. I completely understand that that you're asking that also why they are not getting a treatment. First of all, not everyone is aware that they have misophonia. There are many that just people are coming and say, okay, I know I have this now. I never knew that I have this. So that we are seeing a lot of people with this condition, they don't even know that they have it. We are starting a study at the university, and one of the research people, who's a physician also, she says that, I think I have that. She's what part of IRB says, I think I have that. And she has no, I was talking to two very kind of pronounced neurologists at the university. And I said, I'm going to a misophonia conference in London. I said, what phonia? Misophonia. I said, what is it? Physicians are physicians who are in academia. They have never heard the word misophonia. We got an email for Dr. Jaffe that all of us are circulating among us. This person is a neurologist. Is complaining that why there is no research.
He's a neurologist and psychiatrist.
And psychiatrist. This person said why there is no research about misophonia. In some sort of anger.
Not good enough research.
Good enough research. So what, as I told you, it's pretty new. I mean, we don't know that much about it. That's why there are groups like us and many other groups around the globe. We're trying to find out what else needs to be done. But if a student comes and tells me that, I have this problem, I'm not going to send them for therapy first. I'm going to send them solve their problem right away over there. Find a place that this student at least can get some sort of accommodations. And then find a treatment.